All right, to all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages that arise directly or indirectly from any use of the video content, which is provided as is and without warranties. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz evaluation and assessment. You'll have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. We are looking for a sports medicine physician to join our team. This is a full-time clinic-based position in working in a sports medicine clinic. Please feel free to pass our information along to any sports medicine physicians that you're familiar with that may be a qualified candidate who may be interested. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and slides will become visible. The recording will be available for review from our website tomorrow. Our speaker is Dr. Efren Caballes. Originally from the Chicagoland area, Dr. Caballes attended medical school at the Touro College of Osteopathic Medicine in New York City. He completed residency in Physical Medicine and Rehabilitation at New York University Medical Center, where he also served as chief resident. Following residency, he completed a PM&R Sports Medicine Fellowship at NYU. He is currently in practice as a non-surgical sports medicine physician at Orthopedic Centers of Colorado in the Denver-Boulder area. His practice focuses on diagnostic ultrasound, ultrasound-guided interventions, and orthobiologics. He has a special interest in working with endurance athletes and has helped many professional runners and triathletes, including Olympic medalists who live and train in Boulder. He has also served as a volunteer physician for the Olympic Training Center in Colorado Springs and has been cited in Runner's World. Lastly, he co-hosts a podcast, Ready to Run, which helps runners navigate common running injuries by meeting with clinicians and athletes who share their expertise and personal experiences. He is speaking today on bone stress injury in runners. All right, you should have a little pop-up that comes up that says, would you like to share your screen?
Okay. Are you able to see this yet?
Not just yet.
One second. How about now? Sorry.
Not a problem. Okay, let me move it back to me first and then move it back to you.
Okay.
And then it says show my screen. Yes, we can see your screen now. And we can see your screen in the presenting mode. Ah, perfect. Yes, that looks great.
Okay, great. All right. Sorry about that technical issue. Yeah, thank you for the kind introduction. So I have no relevant financial disclosures. So bone stress injuries pose a unique challenge to clinicians working with runners. And for the athlete, these injuries can be frustrating and disruptive to training. And while training errors or biomechanics are often blamed for running-related injuries, there are often deeper complexities such as low energy availability, hormone function, and relative energy deficiency in sport, which reveal a more nuanced picture. And while most bone stress injuries heal following a period of loading, modified loading and progressive return to running, the high rate of recurrence rate signals a need to address underlying causative factors. So throughout this discussion, I hope to provide some helpful thoughts on how to develop a thorough evaluation and treatment strategy. And if time permits, we'll go through some example cases. So starting with bone physiology. So your skeleton is made up of two types of bone. There's cortical bone and trabecular bone. So when discussing this with patients, I typically give the analogy of an M&M, in which the cortical bone is the thick outer layer and the trabecular bone is the soft inner layer. And understanding the difference is important for understanding how different stress fractures may manifest and behave. So cortical bone makes up a higher percentage of long bones, such as those seen in the tibia and metatarsals. And it's really designed to be strong and handle the impact of running. It also has a high turnover, so it tends to heal pretty quickly after being injured. In contrast, you have trabecular bone, which is also known as spongy bone. So this makes up the inner layer of bone and is present in a higher percentage in the pelvis, the sacrum, femur, and calcaneus. So when compared to cortical bone, trabecular bone it's not as great at dealing with mechanical stress and is more susceptible to injury if there are deficits in nutrition and hormone function. And in the setting of bone stress injuries, trabecular type bone tends to have a longer recovery time. So now moving on to bone metabolism. So it's important to note that bone is not static. Our bones are constantly remodeling, with osteoclasts functioning to remove damaged bone and osteoblasts helping to build new bone. And when you're active and provide the body with enough fuel and rest, your bones adapt and get stronger. So unfortunately, distance running isn't the best way to build a strong skeleton, whereas sports that involve jumping, cutting, and multi-directional movements are a great way to build resilient bone. So this is one reason why we encourage athletes, especially adolescent athletes who have yet to reach peak bone mass, to participate in multiple sports and sports that may involve weight-bearing activities and multi-directional loads, because it has a potential to have a positive effect on bone health and bone remodeling. So what is a bone stress injury? In simple terms, bone stress injuries represent the inability of bone to withstand repetitive loading, which results in structural fatigue and localized bone pain and tenderness. So there's two types of stress fractures to discuss. There's fatigue fractures, in which tend to occur when normal healthy bone is exposed to excessive load and insufficient recovery. The other type is an insufficiency fracture. So this occurs when normal load is applied to weakened bone. So this scenario can be frustrating for the athletes because they might express that their training volume and intensity are low, but will still present with the stress injury anyways. And there are several factors that may play a role, including fueling, hormone function, and conditions of metabolic bone health, which may influence how bone responds to load. And so we'll dive into this more in a few slides when we talk about relative energy deficiency in sport. So bone stress injuries are thought to occur along a continuum that begins with a stress reaction that's characterized by edema in the bone or periosteum, and if left untreated, can progress to a stress fracture, where a fracture line is visible on X-ray or MRI, and ultimately a complete fracture. So working with a high volume of runners, one of the most important things I've learned is to have a high index of suspicion for bone stress injuries. There were probably some that I missed early in my career because I just wasn't looking for them, or may have been confused and thought it was some other type of injury. So bone stress injuries, they typically start with a minor ache or pain, and over time the situation may get worse. So the outermost layer of the bone, which is the periosteum, is rich in sensory fibers, while the inner portion is not. So runners typically won't experience pain with a bone stress injury until it progresses to a location that can sense the problem. And so pain is often made worse with loading activities such as running. And if further along the continuum, pain may present with even walking or standing. Some common things that they might say is that pain does not warm up after the first few minutes, which is in contrast to, say, like a tendinopathy. And in fact, maybe gets worse as they run. So any of these things should raise a red flag and is really a bone stress injury until proven otherwise. And in terms of your physical exam, for some of the longer type bones, such as the metatarsals or tibia, you may notice a single point of maximal tenderness. So they'll often take one finger and point to the spot and say, this is where it hurts. Whereas in a more trabecular type bones, such as the pelvis, the sacrum, or the hip, the symptoms may be quite vague. Other things you can do in terms of physical exam are some form of impact loading, such as pogo hops or single leg hops, to see if that might elicit pain. One of the things I should stress here is that really, you don't be fooled with some of these injuries, and really have a high index of suspicion. And some of the common things I see here are stress fractures that can be confused for other types of injuries, such as the femoral neck, which is often confused as a hip flexor strain, or stress fracture in the femoral shaft, which will often get confused as a quadriceps strain. And you just have to think about the mechanism. In distance running, really there are a lot of high loads placed in some of these areas. So these hip flexor strains and quad strains are really unusual to find in distance running. So really the flag should go up to think about stress injuries as a potential source of the pain. The other one I want to mention here is the calcaneus. These are often presented with plantar heel pain or pain on the side of the heel, depending on what part of the bone is affected. And this can often get confused for plantar fasciitis. So when a runner comes in with plantar heel pain, oftentimes want to get an MRI to rule out calcaneal stress fracture before considering any sort of intervention like an injection, because you never want to inject with, say, cortisone or PRP if someone is actually presenting with a calcaneal stress injury. So some pertinent history beyond pain that we want to dig into listed here. So the bone stress history and exam is often predictable, but it's important to know which questions to ask and to be comfortable asking them. So the number one risk factor for a bone stress injury is a previous history of bone stress injury. So this is often one of the first things I ask. Previous sporting history plays a role, as mentioned before. So running doesn't force bones to adapt as well as, say, soccer, football, or basketball. So if you're meeting with someone that is specialized in distance running very early, then that athlete may have never dealt with the demands of a multi-directional sport and may be starting at somewhat of a disadvantage in terms of their bone health. And while I work with a lot of professional and elite runners in Boulder, I also work with competitive and recreational athletes who are balancing training with full-time jobs. Maybe that job requires standing for 10 to 12-hour shifts, taking kids to daycare, or other life stressors. So sometimes it's not the training error itself that led to the injury. And so while we may be rushed in a clinical setting, it's important to take the time to ask about how your athlete is doing, just in terms of their general well-being. How are they sleeping? Has there been a major life event, a death in the family, or some other event? not just the miles logged in their Strava or their Garmin. And in doing so, may give you a lens into some of the issues that led to the injury in the first place and are important to address when developing a plan for rehab and return to running. In terms of training history, so runners typically focus on the events the day or the week of when the pain started, but with bone stress injuries, there's often a delay of about 3 to 4 weeks from when the workload error occurred to the time when symptoms will manifest and stop, and ultimately lead that patient to stop running because of pain. So because of this delay, I often ask about training history, not just the week of, the day of, but really the weeks before symptom onset. Also note that a lot of these injuries tend to occur at different stages of the competitive season, with many of them occurring in the preseason or early on. So in both males and females, it's important to ask questions regarding hormone function. So in females, we ask questions about menstrual function. So losing a menstrual cycle is not a normal part of training. And in fact, it may be a sign of underfueling or even a gynecological cause such as PCOS. Males can also be susceptible to RED-S, but the actual numbers may be underreported, and this can often be harder to detect. So we have to be thinking about searching for RED-S in these patients as well. So males, they don't have the obvious signs such as losing a period, but they may demonstrate reduced libido or loss of sex drive or loss of morning erections. So it's crucial to assess some of these potential problems and address them before beginning your return to run program, as deficits in energy availability, hormone function, and bone health tend to impact the athlete's risk for another stress fracture, or can even impact their overall health. And deficiency in these areas will take time to return back to optimal function. So even if you have the best return to run plan, if these areas aren't addressed, it'll likely be an uphill battle. So low energy availability, we've mentioned this a few times here. It has major implications for bone health in males and females, but it's often hard to detect. So in simple terms, low energy availability means that the athlete is not meeting the energy demands for their daily function and their sport. And low energy availability can be unintentional because the athlete may not be fully aware or realize just how energy demanding running can be. It can also occur purposefully when athletes are trying to lose weight or with conditions such as disordered eating or eating disorders. And when prolonged energy availability persists, then this can lead to relative energy deficiency in sport. So why does all this matter? Well, runners with low energy availability in this particular study were shown to be 4 times more likely to experience a bone stress injury than low risk runners. And in the study, about 46% and 60% of elite females and male runners, respectively, with signs of low energy availability were reported to have 2 or more bone stress injuries. In terms of diagnosis and imaging studies, plain radiographs or x-rays are often the initial imaging of study we obtain. Typically, this is probably because most insurances require us to get an x-ray before any advanced imaging study. And the thing to note here is that these are often normal in the first few weeks after symptom onset, and often normal unless the injury has progressed into an actual stress fracture. So if there's a high index of suspicion based on the runner's clinical presentation and exam, then an MRI is really the study of choice, which has the highest sensitivity and specificity for detecting bone stress injuries. So once a bone stress injury is diagnosed, one of the first questions we have to ask ourselves as clinicians is to know what is the location of the injury. Each bone in the body is categorized as high, medium, or low risk based on its potential to heal and the likelihood of needing surgery. So starting with the low risk injuries, such as those seen in the posterior medial tibia or the metatarsal shaft, these tend to heal uneventfully in most patients. Medium risk injuries, such as those seen in the pelvis, sacrum, and femoral shaft, tend to heal without complication, but may heal more slowly because they have a higher composition of trabecular type bone, which has just been shown to heal more slowly than cortical bone. Then lastly, you have your high-risk locations, such as the femoral neck, navicular, proximal fifth metatarsal. These are ones you don't want to miss. They take longer to heal. They require longer healing timeline for return to full training and competition, and they may also be at higher risk for something such as a non-union or a malunion. So it's important to be more cautious with these injuries because of their increased risk of complications, some of which may require surgery for full recovery. So besides the location, we also want to know the grade of the injury. So stress fractures are graded on MRI based on the amount of visible swelling in the periosteum and the marrow, and if there's a visible fracture line. And so there's several classification systems that have been described, such as the one seen here, which was described by Fredrickson and colleagues. The common theme with all of the MRI grading systems is that the higher the grade of the injury, the longer the timeline for return to running. So how does a stress fracture heal? So re-injury rates for bone stress injuries are high. It's common for runners to sustain either the same injury or a stress injury in a different bone following the initial injury. I'm sure we've all seen this before. And when it comes to bone remodeling, osteoclast activation and reabsorption in cortical bone has been reported to take approximately 4 weeks, with new bone being replaced around 3 months. And this process takes a lot longer in trabecular bone, hence why bones such as the sacrum, hip, and pelvis may take longer to heal. And for full mineralization, the process can take a year or more. So one of the first questions that the runner may ask is, when can I run? One of the next questions they may ask is, how do I avoid another stress fracture? And really having an understanding of how bones heal and the high re-injury rates are a big reason why we recommend being thorough and conservative in your progression. So in terms of treatment strategy, so even though it could take a full year for your bone to recover, you'll likely be running much sooner. The first step after diagnosing a bone stress injury is to just deload the affected bone. So this may mean a short period of time away from running. We also want to decrease pain and restore pain-free walking. So sometimes this may require use of crutches or a walking boot for a short period. Once we're able to establish pain-free walking, we want to optimize our exercise selection during the rehab to regain skeletal strength and help develop a more robust bone through progressive loading. Repeat MRIs, but not really routine. However, I may consider this follow-up imaging around 8 to 12 weeks in specific cases of, say, high-risk injuries, a high-risk patient, or a high-risk location, because we really want to avoid that premature return to running. It's also important to do a thorough review of all the risk factors that contributed to the injury so that these issues can be addressed before resuming full training. And training errors are the most common reason runners develop bone stress injury. And there seems to be a greater risk with an increase in intensity as compared to an increase in volume. And this is likely because the bone microdamage accumulation tends to occur as a result of the number of loading cycles, the rate of loading, and the magnitude of those applied loads. And load of magnitude, which is a function of running intensity, is by far the most important in terms of bone stress injury risk. So I'll often get referrals from my surgical colleagues where the patient is, say, 4 to 6 weeks out from the diagnosis of a bone stress injury, and I'm asked to perform a running gait analysis to assess running biomechanics that may have led to the injury. And so while this may be an important part of the process at a certain stage in the rehab program and return to run, it's not something I typically lead with. And in fact, these initial consults are often the first time that someone's even discussed fueling, bone health, or hormone function, which may, in fact, probably play a more impactful role in the bone's ability to adapt and heal than making changes in their running gait. So in terms of the workup, for somebody with bone stress injury, I often get a panel of labs. This is just some of the labs I get, and certainly there are others that can be helpful. But some of the important ones to point out are vitamin D, your hormone function in females, so with estrogen, LH, FSH, testosterone in males, and ferritin, as a lot of these can be signs of energy availability and may may interact with the bone's ability to heal. Some other tests I may order are DEXA scans. So the best way to test a runner's bone mineral density is through a DEXA scan. So in endurance athletes, we typically look at scores in weight-bearing bones, such as the hip and the lumbar spine. Someone who's had 2 or more bone stress injuries, or a bone stress injury in a high-risk site, such as the femoral neck, the sacrum, pelvis, navicular, these are the patients where it'd be appropriate to order a DEXA scan. And in terms of interpretation, what we're looking at are Z-scores. So these are scores that are scored as standard deviations. And there are different criteria that are out there from the rheumatologic societies and from ACSM. This one here describes scores between -1 and -2.5 to be considered osteopenia, and scores less than -2.5 to be indicative of osteoporosis. So on a practical note here, we really want to be thorough, but also consider the runner's individual situation. So it's listed a bunch of tests, and it can often feel overwhelming at the end of our initial visit if they've walked away with a checklist of following up with PT, consulting with a registered dietitian, possibly a sports psychologist, completing labs and a DEXA scan, all while telling them they can't run for 6 to 12 weeks. And oftentimes, like, there's just a lot of information overload, and maybe all they heard was that they can't run for 6 to 12 weeks. So I find it helpful to really just check in on these patients after the initial consult, really establish a plan for follow-up and rechecking, because some of these things may not get fully discussed in the first visit, but will be helpful to discuss as time goes on, or even just effectively communicate with other team members so that we're all on the same page, really sending consistent messaging. So in terms of progressive loading strategies, gradual return to running alone is really not enough to be after being diagnosed with a bone stress injury. So changes in weight-bearing status can transiently alter bone quality, muscle strength, and tissue capacity. And while optimizing training and nutrition is a priority after a stress fracture, you'll also want to include some specific exercises that stress your skeletal system in a progressive manner. And to allow the greatest potential for improvement in bone integrity, the loading strategy should be dynamic, low dose, and applied multiple times throughout the day. And this can be accomplished through resistance training and through plyometrics. So bones adapt in a site-specific manner and adapt favorably to exercise by getting denser, stronger, and better able to handle stresses of specific movements and activities. So while non-impact activities such as swimming and cycling may be helpful early on to maintain cardiovascular fitness, I often try to get runners walking as soon as possible because walking has a much more osteogenic potential that can be helpful for increasing tolerance to load. One of the mistakes I made early in my career is that I often would over-prescribe exercise. So if someone has a more sedentary job and is trying to return to a 6-day-a-week training schedule, you really need to be proactive with these patients to get them up and moving. Whereas someone with a more physically demanding job or a home life that may be active, these patients will need to adjust to rehab around their situation and don't necessarily need a laundry list of exercise since their work-life stresses, they're solid and plenty. Because bone becomes rapidly desensitized to loading after about 40 repetitions, I often find it helpful to incorporate low repetition weightlifting early on, as well as frequent bouts of short sessions of exercise throughout the week. So in a practical sense, this might look like 2 to 3 sessions of 20 minutes of resistance training and some plyometric drills at the start of a rehab program, with progression to fewer and longer sessions as we progress. So a sample session early on may look like 2 to 3 sets of squats, 3 sets of 30-second pogo hops, 3 sets of single leg RDLs, 2 sets of 5 to 6 overhead presses, and 3 sets of marching drills. Maybe we could progress that as time goes on. So more and more data suggests that even brief periods of energy deficiency can dramatically elevate the risk of a bone stress injury. And in certain instances, no amount of loading will overcome that energy deficit. So this study by O'Leary and colleagues highlights the effect of meeting energy demands on new bone formation. So in their study, soldiers completing a 15-week infantry battle school used a high-calorie supplement in addition to their normal diet. Training loads were identical between the two groups, but only the supplement group adapted to the training load spike and formed new bone. And as training progressed, new bone formation continued to drop in the control group. So the takeaway here is that when training loads are high, you want to be sure to meet your energy demands to support your body's ability to adapt. And doing a bone loading program without addressing any underlying energy deficits can lead to a situation where bone microdamage continues to accumulate and may set the athlete up for another bone stress injury, since the physiology may lack the energy to support any necessary adaptations. So it's for this reason why I find it critical to involve a qualified registered dietitian into the team so that the athletes can get the most out of our rehabilitation program. Okay, so now on to the question of when can I run? So when strategizing the path back to running, you want to know what the individual specific situation is and what their goals are. So I veered away from many of these like cookie cutter return to run programs, because what works for the recreational runner with the goal of running 1 marathon or 1/2 marathon a year may look very, very different than the professional runner diagnosed with a bone stress injuries 6 months or so before the Olympic Games. It's important to acknowledge that whatever timeline is given, that this is a timeline for when a runner can start running, not return to full training, and certainly not return to competition. So there's a difference between beginning to run, returning to training, and returning to competition. And so there's a few non-negotiables that I have before starting a return to running program, which include a couple of things listed here, such as the ability to unload both of the legs with good postural stability and without pain, progressing the leg over the foot, progressing weight through the forefoot in the first ray, performing open and closed chain contractions, and hopping on one leg in various directions. And so by the time we've discussed return to running, we've already established a walking program, and we want that progression to have been pain-free. And so I'll typically recommend assessing with some form of impact testing to gauge how well a runner can tolerate those peak loads. And so this can consist of 1 minute of double leg pogo hops in the morning, 1 minute of single leg hops in the afternoon, 1 minute of lateral hops in the evening. And if the runner completed their PT strength progression, walking progression, and can tolerate this screening on 2 pain-free sessions, non-consecutive days, no pain during or after, then I'll typically let them go to the next stage of their return to run program. And it's certainly not a validated measure, but tends to work well in a practical setting. So in terms of return to running, really the framework for return to running is fairly simple. It's common for the heart and lungs to improve much more quickly than the bones. So the first few weeks to months of running really is about just running without pain. Running might even look boring. And so we're not really concerned with fitness or mileage or pace at this stage. And the initial few runs are typically recommended to be at a conversational pace, starting with an every other day situation to let the tissues have a real chance to recover. And this kind of lays out how I typically recommend it. So increasing frequency, increasing duration, and the last thing you want to increase in is intensity. And in terms of progressing intensity, I'll often introduce strides, followed by longer tempo runs, followed by interval speed work. And so it's important also to know, well, how much is too much? So it can be really challenging to know if you've done too much, but I often recommend being more cautious than aggressive. So if exercises or running that stress the area becomes painful, it's really best to just reassess. Runners should also be able to complete day-to-day tasks without pain. Any sensation that makes the runner feel apprehensive or if symptoms increase to more than a 1 out of 10 on visual analog scale, it's really best to just stop running at that moment and just reassess. So sometimes you'll also work with a runner who says they're not really great at assessing their own pain because this is really a sport that's trained people to push through pain, which makes it tough to discern what's safe and what's not safe. So that apprehension could often be another thing that may be helpful for that particular patient. So earlier we discussed the high rates of re-injury within the first year after being diagnosed with a bone stress injury, and the importance of having a thorough and conservative approach with return to run. And research has shown that bone is weakest at the initiation of return to running. So this study by Pop and colleagues followed 30 runners for a year following tibial bone stress injury. And the participants saw a steep decrease in bone mineral density of the injured and the uninjured legs for the first 12 weeks following diagnosis. Over the next year, many runners regained their full bone mineral density, but 10 subjects refractured, 8 subjects displayed decreased bone properties, and 6 subjects did not return to running, and 1 actually sustained 3 bone stress injuries within the next 12 months. So this matters because there's often a lag between when running begins and when bone recovers. So runners often will replace normal run training with too much low load cross training, such as swimming or a stationary bike, and really not enough loading that can be more beneficial. So this results in really high cardiopulmonary fitness, but really underprepared bones. So not surprisingly, 1 out of 3 runners will experience a second bone stress injury in the first 12 months after the initial bone stress injury. So the key takeaways here are that we probably underload runners in the recovery from bone stress injury and really need to work on determining the right balance between optimal recovery and rehab. So this doesn't necessarily mean more running, rather we should probably work on optimizing loading exercises earlier so that the athlete is more prepared once they get to that return to run phase. So putting it all together, really we recommend restoring running volume with pain-free running before adding intensity. We also want to acknowledge that there's a linear risk of recurring bone stress injury symptoms with increase in training volume, while there's an exponential increase in bone stress injury risk with training intensity. We also want to progress workload only in the absence of any symptoms during or after running. Also, runners may benefit from a skeletal reset or a deloading week every 12 weeks to avoid accumulation of bone microdamage. So really, these treatments, precision in treating bone stress injuries, it's critical if you really want to work with runners. And over-treating low-risk cases and under-treating high-risk cases really is a significant challenge. And early diagnosis and consistent communication with all the clinical team members and the athlete are really what's crucial for effective management. So I have a couple example cases we'll run through over the next few minutes, and then we'll wrap up for questions. So here we have a patient saw recently, 31-year-old female runner, vague, insidious onset groin pain. Her history is that she's training for the Boston Marathon. Her pain is present during and after impact activity, also present with hiking downhill and with walking. She states that she's a breastfeeding mother of a 2-year-old child. She has a history of amenorrhea with no return of menses postpartum. Also reports poor sleep quality. On her exam, she has focal unilateral tenderness at the inferior pubic ramus and the superior pubic ramus, groin pain with flexion internal rotation, positive impingement signs, groin pain with resisted hip abduction, no pain with sit-up, no pain or no palpable hernia, negative pop test. Interestingly enough, she initially presented to one of the local PTs that I work with. The initial consult was for a running gait analysis. So after this history, they put the patient on the treadmill for about 6 minutes before they had to stop that because of pain and altered gait. Got an MRI. We're looking at an axial image here of the pelvis, and what we see right here is a stress fracture of the inferior pubic ramus with extensive marrow edema extending into the adductor. On our coronal view, same patient, you also see a stress fracture of the superior pubic ramus and the acetabulum. So in terms of bone stress injuries of the pelvis, most of these tend to occur at the inferior pubic ramus near the symphysis. Bone stress injuries of the acetabulum are actually quite rare, but they are seen in endurance athletes and in dancers, often associated with FAI or hip dysplasia. This was not the case in our particular patient. but something to look for. These are due to shearing forces from repetitive contraction from the adductors, the hamstrings, and the rectus abdominis. And also note that the pelvis, as we mentioned, has a high composition of trabecular bone, so it's associated with prolonged healing. Typically, we recommend when you see these 6 to 8 weeks of protective weight bearing and activity modifications, rehab focusing on adductor, hip, and core strength. And the average return to run on these patients is about 8 to 12 weeks. One of the things I really wanted to bring this case up in terms of special considerations is that in postpartum athletes, you really want to have a high sensitivity for detecting relative energy deficiency in sport, because it's becoming described more often in these patients. And just kind of think of the reasons why are the sleep deprivation, lack of routine, altered eating habits, and some of the demands if your athlete is breastfeeding. And in terms of the special considerations in your breastfeeding athlete, one of the reasons this occurs is that calcium is preferentially distributed to the breast milk. And so what ends up happening is that there's this transient loss of bone mineral density, up to 5% during pregnancy and in the postpartum period for breastfeeding mothers, which typically restores back to baseline after about 6 to 12 months. Now, certainly, we still want to encourage breastfeeding because of all the benefits to mom and baby. But just know that if your athlete is in this situation, that we want to supplement appropriately through diet and through supplementation. Okay, so case number 2, we have a 43-year-old male recreational runner, left groin pain. His history is that there's no prior history of bone stress injuries, training for his first marathon. He was actually seen by one of my orthopedic colleagues, had initial x-rays that were negative, he was diagnosed with a hip flexor strain. So he was referred for an iliopsoas tendon sheath injection. So between the time that my surgical colleague saw him and got to me, he actually completed the marathon, but had some difficulty bearing weight in the days afterwards. So when I saw him, he had no pain with resisted hip flexion, but did have groin pain with flexion and internal rotation, groin pain with impingement testing, and notably, he had pain when taking weight off of the affected leg. So pain with offloading. This is one of the signs that you can look for in terms of what we see here, which is a femoral neck stress fracture, which is on the compression side. So with femoral neck stress fractures, there's really 2 types. You have your compression side, which occurs on the inferior or the medial aspect. Then you have your tension side, which occurs on the superior or lateral aspect. And in terms of treatment, these vary quite differently. So compression sided stress fractures, what we look at here is this 50% line. And basically, if it's less than 50% of the femoral neck width, we recommend conservative treatment, non-weight bearing for about 4 to 6 weeks, followed by progressive weight bearing for the next 4 to 6, and return to run on average between 8 to 12 weeks. If it extends past 50% of the femoral neck width, these are the patients you want to send to your surgical colleagues to discuss ORIF. So this is in contrast to our tension-sided stress fractures, which are much higher risk for progressing to either complete fracture or non-union or ABN. So if you see these, really, first thing you want to do is get this patient non-weight bearing with crutches and get them to your orthopedic colleagues as soon as you can, because these might require ORIF. Okay, third case here. So we have a 27-year-old female post-collegiate runner with right-sided low back and buttock pain. Past medical history is significant for an inferior pubic radius stress fracture about a year ago. She also had amenorrhea since high school. And what she describes is a unilateral deep diffuse pain around the SI joint, sacrum, and buttock. A physical exam, very nonspecific. She had some tenderness at the SI joint and the sacrum, some positive SI joint tests, pain with impact loading, pogo hops, single leg hops. So we got the MRI, and this patient was found to have a sacral stress fracture. And so there are different zones which are described for sacral stress fractures. This particular patient had a zone 1 stress fracture, which was located in the sacral ala. One thing to note is if it affects the foramen, such as this last one here seen to the right, that patient may present with some radicular symptoms. So one important thing to highlight here is a study by Fredrickson, where they looked at patients who were diagnosed with sacrum stress fractures. And so there were 12 females and 9 males in their study, and 7 of the 12 had osteopenia, 2 of the 12 had osteoporosis, and 2 of the 9 males had osteopenia. Menstrual irregularities were also detected in about 9 of the 12 females who were described as amenorrheic. So there's a high association with sacral stress fractures and relative energy deficiency in sport. And so these are the patients you really want to screen, get them in the hands of a dietitian, possibly even an endocrinologist, depending on what you see on your DEXA scan. So treatment here, these are commonly associated with lower energy availability. So start with protected weight bearing, crutches until pain-free ambulation, and return to running somewhere in the area of 8 to 12 weeks, with return to pre-injury workloads being about 3 to 6 months. 2 studies to highlight here. So the refuel study, this is one that showed although higher dietary intake resulted in increased weight, menstrual frequency, bone mineral density did not improve compared to control at the end of the study at 12 months. So this just means that some of your patients might be a little more resistant, and maybe need a bit of help to restore their normal bone density. And so there are certain special indications for the use of pharmacologic interventions, such as a transdermal estrogen patch with cyclic progesterone. This was described by Ackerman et al. In British Journal of Sports Medicine in 2019, which showed that at 1 year, there can be an improvement in bone mineral density in patients who are taking the patch if they were oligomenorrheic or amenorrheic. And so that's something I've actually utilized in a couple of my patients with prolonged history. Last case here. So we have a 24-year-old female professional triathlete with left lateral forefoot pain. Pain well localized along the base of the fifth metatarsal, aggravated by running, worsens throughout the run. She has focal tendon palpation at the base of the fifth metatarsal. If you look at her shoes, you can see there's an excessive lateral wear pattern on the shoe. Interestingly, a negative hop test. So these can sometimes be negative, even though you may have a stress injury. So it's not a perfect test. This patient, we had an MRI, and you see some meroedema here at the metaphyseal-diaphyseal junction, which is described as a Jones fracture. So these occur at the metaphyseal-diaphyseal junction, and the reason they occur is that there's a vascular watershed area, so they tend to have a higher risk of non-union. In terms of management, you have 2 choices. You can either cast this patient for 6 to 12 weeks. However, professional elite athletes really recommend surgery in them with an ORIF, as most return to sport, and they do so with a higher rate of bony union. And they return much more quickly than cast immobilization. And so for that surgical patient, just know that recovery for these are slow. First 2 weeks or so, non-weight bearing with a splint. The next 2 to 4 weeks, touchdown weight bearing in a boot, and weight bearing is tolerated. Really no running until there's complete healing at about 10 to 12 weeks or even longer. And really caution with not returning to running too soon. This study here described by O'Malley demonstrated that 3 out of 10 NBA players refractured after return to play average of 10 weeks. So you really want to take these slow. So lastly, in summary, so bone stress injuries, these are common in runners and require a high index of suspicion to diagnose. And rest and gradual return to run alone are not enough for these patients in terms of creating optimal outcomes following bone stress injury. Also, fueling nutrition, really just as important as your rehab program and your return to run strategy. So I'll stop there. Questions?
Okay, we have a question here from Greg, and he asks, when during the menstrual cycle should the menstrual hormones be checked?
Yeah, that's a great question. I'm not sure if there's any specific. Just know that when you are interpreting them, knowing what the different levels are at different phases. Often, honestly, I'll let my endocrinologist or my OBGYN handle these once we get the screening test, because they're just more, they see it more often and understand those intricacies a little bit better.
Okay, the next question is from Audrey. And the question is, if symptoms can show as late as 3 to 4 weeks after workload, what questions should we be asking for that as a red flag?
Yeah, I think the big thing is just some of those like red flag questions, like, how does, obviously you want to ask like, how did training change over the last month, but really how do their symptoms feel as they were progressing through that training? So if someone says, hey, I was able to run, I felt some pain, after I ran, but it subsided after 30 minutes of rest, fine. Whereas if they're at that stage where like they start the run and it just gets continually worse throughout the run, that's your red flag. So asking them, does it warm up, right? And oftentimes, like they just kind of know, because a lot of these runners they'll keep going, and they'll just get to a point where if they push too far, they just actually have to physically stop running. They'll go off for like an 18-mile run one day, and then can't run for 18 steps the next day. So asking those questions, and so those are some of the things I look for.
Okay, the next question is from Arian. Is there any correlation between direction of training and crown of the road regarding injury locations?
So crown of the road, I'm not 100% sure what that means.
Like roads are typically made not with an obvious V, but kind of to allow for water runoff.
So sorry, can you rephrase the question again?
Oh, sure. Yes. So the question is about so depending upon which direction that they're running, if they're always running along one side, if that correlates with the injury location.
Oh, got it. Okay. Not necessarily. I don't know if that's actually been proven in a particular biomechanical study. I mean, in general, like, it's the repetitive stress, the same stress, like, that, bone just rapidly becomes very just desensitized. So if you're doing the same thing the same way every time, as opposed to having variations in surfaces and things like that, I suppose that maybe it could increase your risk, but I'm not sure that's been validated.
Our next question comes from Melvin. And the question is, any suggestions for the vegan, vegetarian, non-meat eating athletes who are runners from a nutrition standpoint?
Yeah, absolutely. I think in general, like this is where I actually have my registered dietitians. I refer to them as they're probably more expert in this arena on specifics. But that being said, I have plenty of one of my most talented runners out here, 60-something-year-old vegan, and really performing at a high level. She probably runs faster than me, and has all these age records and stuff. And so certainly you can have very successful nutrition with those particular diets, but just knowing where you get particular sources from, where you're getting your proteins from, carbs. So in the newest IOC consensus paper on relative energy deficiency in sport, one of the things they talked about is carbohydrates and being associated, lack of carbohydrates and being associated with higher rates of relative energy deficiency in sports and higher injury risk. So often just meeting with a dietitian so that you can know, what you're eating, have it fit within whatever your respective diet choice is, and also when to eat. I think the timing is probably more important than anything, to help metabolize your fuel to help with recovery.
Okay, the next question comes from Daniel. And the question is, do you recommend bone growth stimulators? And if so, which brand or type? And how soon would you begin the use of the bone growth stimulator?
Yeah, so interesting. So I mean, most of the studies you read, not necessarily going to show any strong benefit. So a bone stimulator, I might use it in some of my long bone fractures, particularly if it's someone who's like, more competitive, has a timeline. Whether or not it makes a big impact, I really don't think so. I really think just probably what's more important is really getting that patient in progressive loading. having them squat, single leg squats, marching drills, etc., plyometrics, that's probably going to have more of an impact than your bone stimulator. So I mean, I'll use it as an adjunct. I don't think I'm allowed to speak to specific brands in this presentation, but there's a few out there. One of the things that actually has been shown that's interesting is shockwave. So Adam 1040 out of Harvard, he's done a really interesting study on chronic non-healing or delayed union stress fractures, primarily in long bone, but also I think it was also described in sacrum, where 5 sessions or so, I think is what he described in his study of shockwave therapy, in conjunction with addressing your diet, loading, etc., showed that a lot of these had better rates of healing than control. But one thing that's interesting to note in that study was that at the follow-up, about 30% of them refractured. So sure, it can help you stimulate healing, but really what it really boils down to is really just addressing that fueling deficit.
All right, so people have had a good amount of time to put in their questions, and thank you for an excellent presentation. We did have just over 110 attendees in terms of, so it was a well requested, and we actually connected because this was a requested topic by our attendees. So I appreciate Dr. Caballes for being a speaker on this topic, and certainly by your attendance, we can tell that this was something that was very much of interest by many athletic trainers who do attend our presentations. So thank you very much for your time, Dr. Caballes, and thank you very much to the athletic trainers for all of your time in terms of attending our presentations. Now, certainly moving forward, you will still get that, as always, you will still get that survey of questions. So similar to today, if you do have any specific speakers, please give us the speakers' information. And also, if you have any specific topics, we can always reach out and see if we can find speakers to speak to those topics that you have interest in. So thank you, everyone. And Dr. Caballes, he did provide a lot of contact information there for him. So if you have any additional questions for him, you can reach out to him via those platforms. All right, and I hope everyone has a great evening.
Great. Thank you.